I'm Dr. Neal Buddensiek, your Chief Medical Officer at Benedictine Health System.
I'm Sister Kathleen Hofer, a member of the Benedictine Sisters of St. Scholastica Monastery in Duluth. We sponsor the healthcare ministries. Welcome to Unit 9 of the Ethical and Religious Directives for Catholic Healthcare Services. I will touch on the introduction and background of the ERDs, the Ethical and Religious Directives for Catholic Healthcare Services. Why Catholic healthcare? It is important to carry on Jesus' work of healing as a ministry of our church today. Jesus did have the challenge, go and do likewise. The Ethical and Religious Directives have about a 3-page introduction, which is very, very important to read. They present the theological basis for our Catholic healthcare ministry. What are the ERDs? They are a fundamental guiding document to help leadership in Catholic healthcare understand and apply moral and ethical principles to the constantly changing area of healthcare delivery. In this complex world of illness and providing care for the sick, we need help in making good and right decisions. Sometimes the directives have been misperceived as what we can't do, but that is not the case. They offer a rich theological background for our work in healthcare. We are all called, by virtue of our baptism, to the healing ministry of Jesus. When we're baptized, we are asked to carry out the work of Jesus. Most of us don't know anything about that when we're baptized, but our life is to follow the work of Jesus. Also, in our work as Benedictines and sponsors, we take note of chapter 36 in the Rule of Benedict. Care of the sick must rank above and before all else. Now, Benedict was writing this for us to care for one another as Benedictines, but we extend that to all of God's people. The purpose of the ERDs is to reaffirm the ethical standards of behavior in healthcare that flow from the Church's social teaching about the dignity of the human person. Every person is precious and valuable in God's sight, and life is to be protected. The purpose of the ERDs is also to provide authoritative guidance on certain moral issues that face Catholic healthcare today, and to get help from theologians and leaders in the church as we move ahead in our ministry. The ERDs really started in the 1920s. However, in the 16th century, theologians did begin to consider medical issues. Theologians from various countries got together and established some very general norms for providing health care. But it was in 1915, when the Catholic Health Association was founded, that the need for more directives in healthcare was recognized. In 1921, the first written set of medical ethical norms was developed by the Catholic Health Association. And this was, we have to admit, mostly do's and don'ts at that time, primarily related to surgical procedures. In over 25 years later, the CHA published Ethical and Religious Directives for Catholic Hospitals, and they were focusing at that time on Catholic hospitals. And they involved some theologians and healthcare professionals. These directives became official for a diocese only when they were adopted by the bishop of that diocese. In 1956, the CHA published a revised edition of the 1949 directives. Again, they were official for hospitals only when adopted by the diocesan bishop. The interpretation was fairly uniform among all of the dioceses with all of the bishops. However, there were some differences. And at that time, some people said, well, this is geographic morality because it was a little different in different parts of the country. In 1971, the development and refining of the ERDs was taken over by the National Council of Catholic Bishops, the NCCB. This made the directives a much more official document in the church. The NCCB approved revised ethical and religious directives for Catholic healthcare services, broadened from hospitals, which initially were stated. They moved beyond prescriptions to include issues of social justice and human dignity, and theological background for clinical issues. They added Part 6 on relationships with other than Catholic healthcare facilities. It was at this time that many mergers were beginning to take place. Sometimes they were between Catholic facilities, but at other times it was a Catholic facility and an other than Catholic facility. This happened right in Duluth when St. Mary's Medical Center merged with the Duluth Clinic. This was most unusual. We worked with CHA, we worked with bishops, we worked with canon lawyers, we worked with theologians, and put together a plan that really worked for a Catholic facility and an other than Catholic facility. In these 1994 directives, they were worked on for over a 6-year period. This was a very big undertaking by the NCCB. They had input from Catholic healthcare people, theologians, 4 major drafts before they were actually finalized in 1994. In 1999, the NCCB started again to look and revise the documents. They had 3 drafts that year and added more individuals, more healthcare leaders, more theologians, CHA staff, additional bishops, and then published the 2001 revision. And since then, there have been other revisions in the ERDs. Applying the ERDs is sometimes not easy. They do not provide ready answers, usually require interpretation and application to very concrete situations. There may be different but valid conclusions in varied cases. Some may interpret the ERDs more narrowly or more loosely than warranted by the Church's moral teachings. And the directives are not exhaustive on the moral teachings of the Church or issues of healthcare ethics. Healthcare institutions often need assistance from those who have more competence in theological or ethical issues. The structure of the ERDs begins with a general introduction. In this introduction, human dignity is expressed as well as common good. It is a very, very important 3 pages to read when becoming involved with the ERDs. There are 6 parts, with each having a biblical and theological development as its introduction. Again, very important to read the introduction to each section. In the entire directives, there are individually numbered specific directives, 72 of them addressing specific issues. Part 1 of the directives deals with the social responsibility of Catholic healthcare services. These services are based on Catholic social teaching, as well as the many clinical issues in healthcare. Catholic healthcare ministry is rooted in a commitment to promote and defend human dignity. We stress human dignity over and over again. As well, the biblical mandate to care for the poor requires us to express this in concrete actions. Again, care for the poor is very important. The Catholic healthcare ministry seeks to contribute to the common good. As well, Catholic healthcare ministry exercises responsible stewardship of available healthcare resources. In today's world, stewardship is so very, very important, and this is stressed in our work in healthcare. Lastly, within a pluralistic society, Catholic healthcare services will encounter requests for medical procedures contrary to the moral teachings of the Church. Catholic healthcare does not offend the rights of individual conscience by refusing to permit medical procedures judged morally wrong by the teachings of the Church. Catholic healthcare is there always to support human dignity and the right to life. And this is extremely important in everything that we do and in all of our decisions. Following the introduction in Part 1, there are 9 specific directives that deal with our social responsibility.
Part 2 invites us to an understanding of the pastoral and spiritual responsibility of Catholic healthcare. Catholic healthcare respects and upholds the dignity of every individual we provide care to, with the knowledge that that individual is made in the image of God and is of infinite worth and has an eternal destiny. Catholic healthcare institutions are a community of health and compassion, and care is not limited to just the physical. It also embraces the dimensions of spiritual, psychological, and social that are part of that person. Hence, the pastoral care is an integral part of Catholic healthcare. There are 13 specific directives in Part 2. I will highlight a couple of them. Directive 10 ensures the professional preparation and credentials for spiritual care staff and addresses the particular religious needs of residents. Directive 10 through 14 and 2222 respect the proper authorities in each religion or Christian denomination regarding appointments. Directive 22 and 11 maintain an ecumenical staff, or that an appropriate referral to a spiritual care provider is made. Directives 12 through 20 and 10 address the sacramental needs of Catholics, specifically the Eucharist, the body and blood of Jesus that provides healing. Part 3 provides a deeper understanding of the professional-patient relationship. We must remember that the relationship between the professional provider and the resident or patient is based on mutual respect, trust, honesty, and appropriate confidentiality. This is a sacred covenantal relationship. We must remember that the personal nature of the care provided must not be lost, even when a team of caregivers is involved in that care. Part 3 has 15 specific directives. I will highlight a few of them. Directive 24 encourages and respects the creation of advanced directives. Directive 25 focuses on respecting choices of surrogate decision makers when the resident is not able to make those decisions any longer. Directive 26 and 27 honor residents' right to make treatment decisions, specifically as it relates to informed consent. Directive 32 respects decisions to forego treatment, creating a distinction between ordinary or proportionate means, known as morally obligatory, and extraordinary or disproportionate means, known as morally optional. Directive 33 considers the whole person when deciding about therapeutic interventions. Directive 34 respects privacy and confidentiality. Directive 36 provides compassionate and appropriate care to victims of sexual assault. And Directive 37 requires one to have an ethics committee or an alternative form of ethical consultation available when ethical dilemmas do arise. Part 4 addresses issues in care for the beginning of life. We respect the human dignity of each and every individual that we serve, and the Church's commitment to this human dignity inspires an abiding concern for the sanctity of human life from its very beginning at conception, and to dignity of marriage and the marital act by which human life is transmitted. The Church's defense of life encompasses the unborn and the care of women and children before, during, and after pregnancy. Part 5 addresses issues in the care of the dying. Christ's redemption and saving grace embrace the whole person, especially in his or her illness, suffering, and death. The Catholic healthcare ministry faces this reality of death with the confidence of faith. And in that face of death, for many, a time when hope seems lost, the Church witnesses to her belief that God has created each person for eternal life. A Catholic healthcare institution will be a community of this respect and love and support the residents and their families as they face death. We do have a duty to preserve our lives, but that duty is not absolute. In this day of use of medical technologies that are ever advancing, one must judge in light of the Christian meaning of life, suffering, and death, whether to use those means. There are 12 directives in Part 5. I will highlight just a few. Directive 55 reminds us to help residents prepare for death and provide necessary information for that decision-making. Directives 56 and 57 remind us that a resident may forego extraordinary or disproportionate means of preserving life, and no moral obligation is required to employ disproportionate means. This means that if treatments are too burdensome, there is no moral obligation to continue or to even start. Directive 58 shares presumption in favor of providing nutrition and hydration, as long as the benefit outweighs the burden. Directive 59 shines forth respecting the free and informed judgment of the resident to accept or refuse life-sustaining treatment. Directive 60 is clear that we must not engage in euthanasia and physician-assisted suicide. And Directive 61 assures appropriateness of good pain management, even when death may be indirectly hastened through use of pain medication analgesia. Catholic healthcare has been at the forefront of being excellent at supportive and palliative care. Directives 63 through 66 encourage appropriate use of tissue and organ donation. Part 6 provides guidance on forming new partnerships with healthcare organizations and providers. In this dynamic time of change and realignment and reform in healthcare, ever more partnerships are being considered in the strategic vision and mission of Catholic healthcare. And we know there are other than Catholic healthcare institutions that can provide great value and service in partnership with Catholic healthcare. And so we must witness to this ethical commitment to influence the healing profession. These new partnerships can pose serious challenges, though, to the moral tradition of Catholic healthcare institutions and services. Thus, we must have an attitude and an action that align and do not create risk of scandal, which can result when partnerships are not built on common values and moral principles. There are 10 specific directives in Part 6. I will comment on a few of them. Directive 69 establishes a multi-jurisdictional review process that requires bishops affected by all markets affected in a collaborative arrangement to try and reach consensus about the morality of such. Directive 70 forbids Catholic healthcare from engaging in immediate material cooperation in intrinsically evil actions. Directive 73 ensures neither its administrators nor its employees manage, carry out, make facilities available for, make referrals for, or benefit from the revenue generated by immoral procedures. Directive 75 prohibits Catholic institutions from establishing another entity that would oversee, manage, or perform immoral procedures. Directive 76 reminds representatives of Catholic healthcare institutions who serve on governing boards of other than Catholic healthcare entities that they should make their opposition to immoral procedures known and not give their consent to such procedures. Directive 77 reminds us to immediately notify the diocesan bishop if our Catholic institution discovers that we are wrongly cooperating with any immoral procedure.
Now that you've had an overview of the ethical and religious directives, we have a question for you to consider. Which part of the directives is most helpful to you as a governance member of the BHS?
Thank you for your attention and your continued service in this healthcare ministry.